بسم الله الرحمن الرحيم. النهاردة موضوعنا عن اليوفيا أو اليوفيال تراكت. اليوفيا دي هي الميدل فاسكولار كوت اوف ذا اي، بتتكون من 3 أجزاء. الجزء اللي قدامي اللي هو الأيرس، وبعد كده منطقة السيلاري بودي and the last portion is the choroid. المحاضرة هنقسمها لجزئين، جزء خاص بالانفلاميشن اللي هو اليوفيتس، والجزء التاني خاص بالمالجنسي أو الميلانوما. احنا قسمنا اليوفيا ل3 اجزاء، فعشان كده التهابات اليوفيا برضو هنقسمها ل3 اجزاء: anterior uveitis, intermediate uveitis and posterior uveitis. anterior uveitis بتشمل inflammation either of the iris which is called iritis or of the anterior part of the ciliary body which is called cyclitis or iridocyclitis, inflammation of the iris and the anterior part of the ciliary body. The posterior uveitis, which means inflammation of the posterior part of the uveal tract. Panuveitis, which means inflammation of the whole uveal tract. What are the etiologies of the anterior uveitis or iridocyclitis? Either exogenous uveitis or endogenous uveitis, secondary to another disease in the eye or associated with systemic disease. And according to its course, it can be divided into acute and chronic uveitis. The clinical picture of the acute iridocyclitis include symptoms: pain, which is characteristic neurologic pain due to toxic irritation of the sensory nerves, spasm of the sphincter pupillae, dull aching pain, and referred to the eyebrow. Photophobia, which means inability to open the eye in normal light. Lacrimation, blepharospasm, and diminution of vision due to many factors such as corneal edema, turbidity of the aqueous and vitreous, spasm of the accommodation, myopia of 1 to 2 diopter, toxic maculopathy, and keratic precipitates. The signs of acute iridocyclitis includes lid edema, circumcorneal ciliary injection, keratic precipitates, which means the accumulation of the inflammatory cells and it's sticking to the corneal endothelium. Anterior chamber is formed with exudate, plasmoid aqueous cells and flare. Aqueous cells, these are the inflammatory cells, and the aqueous flare means the exudation of proteins from the blood vessels of the uveal tract in the anterior chamber. Hypopion, which means pus in the anterior chamber. The iris will lost its pattern and leading to what is called muddy iris. Pupil usually is small, irregular, and sluggish. The lens, there is iris pigment on the anterior lens capsule in acute phase. Ciliary body, tenderness and pseudomyopia. The vitreous cells and the exudate, which may lead to what is called cyclitic membrane. Tension may be either hypotony or secondary glaucoma. What are the complications of acute iridocyclitis? In the iris, there is synecdoche, which means adhesion between the iris and the adjacent structures, either anteriorly to the cornea, which may be central or peripheral, leading to peripheral anterior synecdoche, or posterior to the lens or vitreous, either at one point or multiple points, leading to festoned pupil, or ring synecdoche, leading to seclusopupillae. The pupillary area, there may be a membrane occluding the pupillary area, leading to occlusopupillae. Also, the iris may show patches of iris atrophy due to inflammation. Secondary glaucoma, and its mechanism at the early phase is the hypopion and the hypersecretion of the aqueous, while at late phase it is due to peripheral anterior synecdoche, secluso, and occlusopupillae, which may lead to what is called iris pompe, means bulging of the iris due to entrapment of the aqueous in the posterior chamber as a result of the total posterior synecdoche. The lens, there is complicated posterior subcapsular cataract, formation of cyclitic membrane, and with contraction of this membrane may lead to retinal detachment, cystoid macular edema. How to diagnose a case of iridocyclitis? By careful history taking, careful ocular and systemic examination, and appropriate laboratory investigation based on the most probable etiology. Regarding the investigation for a case of acute iridocyclitis, you should perform full blood picture, immunological tests such as HLA testing or human leukocytic antigen testing, radiological examination, chest X-ray, CT scanning and MRI for multiple sclerosis, ultrasonography to evaluate the posterior segment, especially in case of media opacity, ocular tissue sampling, arthritis. You should perform HLA P27, rheumatoid factor, anti-nuclear antibodies, sarcoidosis. You should perform angiotensin converting enzyme. Also, you can order the syphilis serology, the toxoplasmosis, and the tuberculin test. Iridocyclitis should be differentiated from other causes of acute red painful eye, such as acute conjunctivitis, acute congestive glaucoma, and corneal ulcer. This table shows the difference between the four categories of acute red painful eye, and these are the differentiating point, the presence of pain and its characteristics. The visual acuity is usually affected in corneal ulcer, iridocyclitis, and acute glaucoma, while in conjunctivitis there is no affection of the vision. Corneal ulcer, ocular association, there is discharge in conjunctivitis, photophobia, lacrimation in corneal ulcer, photophobia in iridocyclitis, and in acute congestive glaucoma there is severe photophobia. The general association is usually associated with acute glaucoma or, in cases of iridocyclitis, secondary to systemic disease. In corneal ulcer, you have a positive fluorescein dye test, while there is KPs in acute iridocyclitis and corneal edema in acute congestive glaucoma. Anterior chamber is usually normal in cases of conjunctivitis, but in acute iridocyclitis there is aqueous flare, plasmoid, aqueous hypopyon, and in glaucoma there is shallow anterior chamber. The iris has a characteristic muddy appearance in acute iridocyclitis, and it may also be muddy in case of acute congestive glaucoma. The IOP is very high in case of acute congestive glaucoma, while in other cases it may be normal, and in case of acute iridocyclitis it is either normal, high, or hypotenuse. How to treat a case of acute iridocyclitis? You should start with a specific treatment in case of a specific etiology such as TB, syphilis, herpetic, or toxoplasma. Regarding local treatment, atropine is very important in case of acute iridocyclitis, as it dilates the pupil to prevent the posterior synecdoche, relax the ciliary muscles and sphincter pupillae, relieving the pain, relax the ciliary muscle and improving its blood flow. Corticosteroid is considered the cornerstone in a case of iridocyclitis. Either drops at birthday or ointment at night, and in severe cases we can give subconjunctival injection. Hot fomentation to increase the blood flow, and dark glasses to avoid photophobia. Systemic treatment with systemic steroid, prednisolone tablet 5 mg. The dose may be mild 15 mg, moderate 30 mg, and severe 60 mg per day. And in very severe cases we can reach up to 120 mg per day. But you should consider the contraindication for corticosteroid treatment. Ocular, such as suppression, viral infection, glaucoma, ulcers, and general pregnancy, malignancy, hypertension, diabetes, heart failure, uremia, peptic ulcer, and pulmonary TB, as it may lead to activation of TB. Non-steroidal anti-inflammatory drugs to supplement the corticosteroids, systemic antibiotics, analgesics for pain, and immunosuppressive drugs. Once complications occur, you should manage the complication. Glaucoma, medical treatment using Diamox, and you should not use myotics. Paracentesis to hypopyon or hyphema. Surgical treatment using peripheral iridectomy, external fistulizing operation. Cataract extraction, either intracapsular or extracapsular, or using ultrasonic power phacoemulsification. Cyclitic membrane, doing vitrectomy, and blind painful eye inoculation and cosmetic implants. This is the acute iridocyclitis. Let us discuss the chronic iridocyclitis. It is gradual progressive course with exacerbation and remissions. It may be granulomatous or non-granulomatous. The symptoms, mainly gradual diminution of vision with mild pain, little symptoms. Regarding the sign, there is ciliary injection, deep anterior chamber, muddy iris, keratic precipitate, dust-like opacities in the vitreous, hypertensive iridocyclitic crisis. The complications of long-standing iridocyclitis include band-shaped keratopathy, sclerosing keratouveitis, synecdoche, rubeosis iridis, which means new vascularization at the iris atrophy or nodules, complicated cataract, secondary glaucoma, and atrophia bulbi. This is the acute iridocyclitis and the chronic iridocyclitis. What about inflammation of the posterior part, which is called choroiditis, or inflammation of the choroid? It may be either suppurative and non-suppurative. The suppurative includes endophthalmitis, internal, which include inflammation of the internal structure of the eye, or panophthalmitis, which include inflammation of all layers of the globe. Non-suppurative, it can be classified into granulomatous or exudative. Granulomatous, chronic infection such as TB or syphilis. Exudative, due to acute allergy. The non-suppurative choroiditis, its causes are ocular allergy, endogenous, some syndromes, and bacterial allergy. The clinical picture, there is defective vision, field defect scotoma, macro or micro or metamorphopsia, and photopsia, which means the flashes of light. The course passes into many stages. Active, in which there is ill-defined, rounded, yellow patch deep to the retina with hazy edge and cloudy retina, hidden choroidal vessels. Atrophic, which means white fibrosis, scattered pigments more at the periphery with negative scotoma. Suppurative choroiditis, due to local causes or systemic causes. Local causes such as perforating wounds, accidental or surgical, or perforated corneal ulcer. Systemic, due to pyemia, septicemia, or cerebrospinal meningitis. Endophthalmitis, this means inflammation of the internal structure of the eye pool, sparing the cornea and the sclera, and its symptoms are marked drop of vision, severe pain, redness, watering, and photophobia. The signs include conjunctiva and ciliary injection, chemosis, keratic precipitates, turbid aqueous, cloudy vitreous, leading to formation of cyclitic membrane, and its contraction leads to traction retinal detachment. Hypotony, which leads to shrinkage eye. The treatment of endophthalmitis requires hospitalization with vitreous aspiration for smears, gram and gemcitabine, and the culture sensitivity test. Anterior chamber paracentesis, aspiration of the aqueous for smears, culture and sensitivity test. You should start antibiotics, intravitreal, vancomycin and ceftazidime to cover the gram-positive and the gram-negative organism. Also, give subconjunctival injection of vancomycin and ceftazidime. The typical treatment include vancomycin drops, ceftazidime drops, and the systemic amikacin 14 mg per kilogram either intravenous or intramuscular every 8 hours for 5 days, or ciprofloxacin 500 every 12 hours for 5 days. You should monitor the kidney function from fear of nephrotoxicity of antibiotics. Topical and systemic steroid can be given, and lastly, you should do vitrectomy if there is no improvement of the condition. What are the indications of inoculation? Blind and painful eye in case of absolute glaucoma, blind and disfiguring eye, shrunken or staphyloma, intraocular malignant tumor, dangerous eye due to perforating injury for the fear of sympathetic ophthalmitis. Panophthalmitis, it means inflammation of all layers of the eye, including the sclera and the cornea. The symptoms as endophthalmitis in addition to general constitutional symptoms such as fever, headache, vomiting, and the vision usually there is no perception of light. Signs of endophthalmitis as endophthalmitis in addition to lid edema, congestion, proptosis, corneal edema or haze, hypopyon, the vision, no perception of light, there may be perforation leading to pus and shrinkage eye. The treatment as endophthalmitis by giving systemic, topical and subconjunctival intravitreal antibiotic, but when no perception of light, evisceration to remove the cornea and the internal content leaving sclera to prevent the extension of inflammation into the meninges. What are the differential diagnoses? Other causes of acute red painful proptotic eye such as orbital cellulitis, cavernous sinus thrombosis, acute dacryoadenitis, tinnitus, periostitis, and acute inflammation of the paranasal sinus. This is the inflammation of the uveal tract. What about the malignancy? The most important is the malignant melanoma of the choroid, which is usually unilateral, unifocal, occur primary and above 40 years in white races. The clinical course passes into some stages. The quiescent stage, there is no symptoms in this stage. Glaucomatous stage, due to congestion and increased vascularization, leads to aqueous hypersecretion, increase the volume, push the vitreous lens iris forward, leading to pupil and angle block, obliterate one or more vortex vein, necrotic tissue, malignant hypopyon, and obstruct the trabeculae. The extraocular extension, in this stage there is extension along the scleral canal of the ciliary vessels and the nerves. Distant metastasis to the liver, leads nodules and jaundice. The investigations include radioactive P232 uptake, ultrasound, A or B scan, in which there is characteristic mushroom appearance of the choroidal melanoma, the trans-illumination through the sclera, fundus fluorescein angiography, CT, and MRI. Treatment, either by observation in eyes with a small lesion or if there is a suspicious of choroidal nevus, single eye with a slowly growing tumor. You can perform local resection for small peripheral lesions or radioactive plaques fixed to the globe, which may be suitable for small or medium-sized tumors near the posterior pool. Inoculation is indicated for large melanoma. external beam irradiation prior to inoculation to lessen the risk for metastatic lesion, transpupillary thermotherapy, and palliative treatment in hopeless case. Thank you.